Welcome everyone, and thanks for tuning in. We understand you got the treat of first some music and then our technical resolution there. So I'm glad you know that we're here and we're about to start the webinar proper. So my name's Ken Wong, and I'm here on behalf of the RGP Toronto, who's hosts this webinar series. Welcome all. We know there's people from afar as well, as far as Eastern Canada tuned in, so we're happy to have you here. Deborah Brown, our practitioner, is from Eastern Canada too, so she feels right at home. Just a little bit of housekeeping. If you do sign in by phone, if you could please hit the mute button on your phone and not unmute. We hear a lot of echoes and sometimes dogs barking in the background, and while we are friends of dogs, we don't think that would help with the ambiance of this webinar. We do want you to dialogue with us, and you can do so using the chat box in the lower right of your screen. There's a line there that you can type into, and everyone can see what you're typing in, and so we can all share in this discussion. Apart from that, please enjoy the show and let us know if you experience any problems. I've left Wendy Zay, our teammate's email address at the top, close to the top right of the screen, and you can email her for support if needed. But without any other further introduction, I'd like to turn things over to our speakers. You know, I'm really excited about this topic. Language is such a powerful and influential thing. You know, we all know when we've read a fantastic book how that leaves us feeling. You know, we know how our world leaders, through their use of language, can either horrify us or inspire us. And the same is true when we're working with the patients we care for, particularly patients who have extreme difficulty expressing themselves. So Deborah Brown is a nurse practitioner for the Senior Friendly Care Strategy here at Sunnybrook Health Sciences Center, and her colleague and teammate Mary-Lynn is a clinical manager of professional practice at Trillium Health Partners. And together, Deborah and Mary-Lynn have co-chaired for the past over 2 years a group called TAHSN, the Toronto Academic Health Science Network, teaching hospitals and their partners in Toronto to produce a guideline on working with person-centered language to optimize our care planning and our understanding of patients who can't express themselves well. So this is today's webinar. Please join in the discussion. I'm going to turn things over to Deborah, who will lead us through the first part of this discussion. Thanks, everyone.
Well, thank you, Ken, for that wonderful introduction, and welcome to all of you and gratitude for signing in on what we hope will be a very interesting time together. Mary-Lynn and I want to first talk a little bit about our objectives with you, and then we'll start into our slide presentation. So what we would like to do in the next close to an hour is really describe the impact of language on patient care and really introduce to you our Toronto Academic Health Sciences Network Community of Practice Person-Centered Language for Responsive Behavior document. That is a lot of words, and what we'll often do in our presentation, instead of spelling out or enunciating all those words, we'll certainly call it our TAHSN Community of Practice, and that's the body from which much of this work sort of started from. We also want to identify how our document can be used and the potential to impact on patient care, and we're hoping to get some feedback from all of you as well, and discuss possible alignments with quality improvement initiatives across care facilities. So that's what we're hoping to do, and we want to begin this discussion by having you reflect on the power of words. The power of words really to create a vision or an expectation, because we know that words cannot change reality, but they can often change how people perceive reality. And words very much create filters through which people view the world around them. For instance, think about this. Have you ever had a friend describe a person you are about to meet for the first time as untrustworthy, and you became predisposed to view that person as untrustworthy, regardless of the person's actual level of trustworthiness. So behavior analysts and psychologists will often say that that single word that you heard at the beginning, untrustworthy, creates a filter or a primacy effect that predisposes you to have a set view of that person before you even really get to know them. So this primacy effect can be quite powerful in behavior. And we feel this happens and transcends into care situations as well, where our thoughts, words, and perceptions certainly prime us in many situations to act in certain ways. Because the way we talk influences the way we think and ultimately what we do. So what we're going to do now is show you a few pictures, and we want you to reflect on what are some of those common words or descriptors that you may have seen in patients' records or documents that describe what may be happening. We don't want you to give this a lot of thought, but just off the top of your head, look at this picture and what are some of the common words you've read or you've heard staff use to describe this situation. We'll give you a few minutes to get to that.
Please type in the chat box and share with us your thoughts. And I'm seeing a very strong no thank you there.
Okay, so what about the words uncooperative? How about non-compliant with medications? How about resistance to care? Have you heard those kinds of things? I'm sure you probably have. Okay, here's our next picture. How would you describe, or how have you seen this described in care settings that you're involved with? What do you think this woman is doing? Please type in a few words for us. What do we often call patients who are doing this kind of thing?
She's staring longingly at the exit, trying to find a way to escape.
What is the label we give patients who are often doing this?
You know, Deborah, I've often heard the term exit seeking.
So we often say the exit seeker, right? Right. Okay, let's go to our next picture. How have you seen this kind of behavior described?
Well, I would say that's a staff member looking through patient records.
Oh, that's very good. But often we've seen the words rummager, you know, somebody, the rummager kind of thing. So what we were trying to do with these few pictures is start you to think about what are some of those typical words that we see all the time, and want you to consider two things. Number one is, what effect do you think those priming words have on our ability to really understand what's going on? And what effect do those words have in creating or mitigating an effective care strategy plan for the patient? So how really do those words help us understand and help us to care for patients? And when we go through this presentation, I think you'll understand at the end, at least, that these kind of words actually can do a lot of damage. So, you see, in our care environments, care providers often use these kinds of terms like aggressive, difficult, or the challenging patient when they encounter a person presenting with symptoms of disturbed perception, thought, mood, or psychomotor behavior. And the language, such as this, can contribute to a culture of labeling and blame, often impeding the development of a supportive and caring relationship between the person and his or her caregiver. And the consequences can be dire. Once this kind of language is used to describe a patient's behavior, it tends to label the patient and perpetuate a trajectory of negative consequences during hospitalization that transcends into discharge. The language and the words often stick in the minds of caregivers. It influences their opinions and impacts their care plan. And care providers talk and think about things to be managed, like the screamer, the wanderer, or the resistor, instead of people to be understood. So what do we mean by that in the context of care? So let's look at this a little closer by examining a case scenario. And we're going to look at the case of Miss Sharp. Miss Sharp is an 84-year-old female living alone in a bungalow. Neighbors called 911 because they saw her wandering around the streets without a coat or hat in the middle of January. Her home was unclean, spoiled food in the refrigerator, and there were piles of garbage in the kitchen. She was confused and agitated. EMS were concerned and took her to the hospital. Well, the EMS documentation read that she was aggressive and combative when they assessed her. She resisted getting into the ambulance and kicked the EMS crew. On arrival to ED, she was screaming, kicking, and attempting to bite the crew and the triage nurse. She was quickly given Haldol, 2 milligrams IM, and put in restraints. Mrs. Sharp's past medical history was hypertension, TIAs times 2, atrial fibrillation, osteoarthritis, and note was made she had mild dementia. It has been unclear if she has been taking her medications as ordered. And with further examination and workup in the ED, it revealed she had rapid atrial fibrillation with a heart rate of 152, hypertensive at 160/90 with a fever and diffuse joint pain. She was noted again to be confused, agitated, and resistive to exam. She was admitted to the hospital with rapid atrial fibrillation and the diagnosis of delirium. And on the inpatient unit, again was noted to be confused and uncooperative with care. During her stay on the inpatient unit, she was refusing to take medications because she really thought she was being poisoned. She would not let staff perform personal care on a consistent basis, and often 4 staff were needed to perform personal care successfully. She at times swung her cane at staff and kicked and hit nurses, shouting profanities. During her hospital course, she was often described as aggressive and combative. She had scheduled Haldol ordered on a regular basis and also a PRN Haldol order in her chart. She was seen by geriatric medicine and psychiatry, and by day 14, she was deemed medically stable, atrial fibrillation reasonably controlled, her osteoarthritic pain quite well controlled, and delirium was beginning to resolve. However, she had, sorry about that, I just thought I had a mix-up in slides. So we'll continue on. She had significant deconditioning as a result of time spent in restraints and the effects of the antipsychotics that were given her on a regular basis. She was quite drowsy a lot of the times, and inconsistent participation with physiotherapy. The team felt she would benefit with admission to a slow-stream rehab program to regain function and hopefully be able to return home someday. However, she was declined by 3 slow stream rehab facilities due to documented behaviors of aggressive and combative. She remained in acute care hospital for 6 more weeks and eventually was discharged to a nursing care home and did not return to her primary care residence. So, we have to reflect on this situation, which has happened more than once in our care facilities, and think about and ask ourselves, how could this situation have been different? And significantly, what we want you to concentrate on is what role did language play on the events that occurred? And also, what do we need to change in our healthcare system to address this kind of issue? So right now, I am going to hand you over to my colleague Mary-Lynn, who will introduce our perspective on what needs to change through the collective voice of our TAHSN senior-friendly community of practice.
And we're back with Mary-Lynn.
Hi everyone. Thank you for bearing with us during our quick change here at seating at the computer desk. I would like to now carry on with this and talk to you a little bit more about how this might have been different. Firstly, I want to talk to you about the Toronto Academic Health Science Network Senior Friendly Community of Practice. As Deb mentioned at the start of our presentation, this is the organization that prompted the creation of this person-centered language document. The TAHSN Senior Friendly Community of Practice is a consortium of the University of Toronto and affiliated academic hospitals, and our mandate is to develop collaborative initiatives that can optimize, advance, and sustain the academic mission of high-quality patient care delivery, as well as education, knowledge transfer, and research innovation. All of this with a focus of better care for our older adults. And our community of practice decided that what we really wanted to talk about was responsive behaviors. We felt that there was a common need to enhance our practice with responsive behaviors across all of the member organizations, and from those conversations, it seemed like language was a natural place to start. As Deb mentioned earlier, we recognize that what we say influences what we think and ultimately what we do, and that influences how we care for persons with responsive behaviors, and so it was a really nice fit. A little bit about responsive behaviors. One of the reasons that prompted us to tackle this is that they're so common. Between 35 to 90% of people with dementia will experience a responsive behavior at some point in their dementia journey. And we know, for example, coming into hospital aggravates that if the person develops delirium, because delirium can exaggerate responsive behaviors of dementia. We also know that responsive behaviors can occur for someone who is cognitively intact but is experiencing an episode of delirium. And just to make it more interesting, you can have more than one responsive behavior at a given time, which leads to complexity and challenges for families, caregivers, and health professionals. So here is our document. We created a person-centered language for responsive behaviors document. It's really more of a guideline, and it will be utilized by our TAHSN organization member hospitals. What we've done in this document is to describe person-centered language and broken it down by categories of physically responsive behaviors, verbally responsive behaviors, and those that are a combination of both physical and verbal responses. And we have also intentionally created this document to be applicable to diagnoses broader than dementia across the healthcare continuum. Historically, when speaking about responsive behaviors, it's usually only in the context of dementia, but we recognize that there are many other clinical scenarios in which someone would have a responsive behavior, and we wanted this to be readily utilized in those scenarios as well. We have created it with case examples that demonstrate person-centered documentation and help to guide application of the key principles. If you walk away from this presentation today remembering only one thing, I want you to remember this slide, please. And that is that actions, words, and gestures are a response to something that's important to the person, and they have meaning. And at the bottom line is that behaviors are a means of communicating needs and concerns, and it's up to us as the people surrounding this person who has difficulty communicating that we have to do the detective work. We have to do that deeper dive to figure out what the meaning is behind that behavior. Further to that, when we are looking at someone with responsive behaviors, it's important to look past pathology and look for the root cause of the behavior. And what I mean by that is don't just say, oh, they have advanced dementia, of course they're having behaviors, and let's give them some Haldol, or let's restrain them, or let's put them on a secure unit. Rather, we're asking that you look beyond that and say, what is their behavior trying to tell us? How can we create a comprehensive understanding of this person and what their behaviors, what their expressions mean? The next level to that is that the language we use has to be specific and objective so that we can have a shared common understanding of what these behaviors mean, and also to care plan appropriately for those patients so that we can then track whether what we're doing is actually making things better or worse. How we talk about responsive behaviors matters, and I can't stress this enough. Having had a parent who has had some delirium and responsive behaviors associated with delirium, it can be very upsetting and it can be very insulting to hear staff members refer to your loved one as that confused old lady down the hall or the screamer in room 15. For the person with dementia, that is even, I can't imagine, it must just even be more demoralizing and dehumanizing being labeled in such a negative fashion. And for us as a care team, it colors our expectations and interpretations of that person and what we think their behavior means and what they should be doing. So this is a screenshot from the person-centered language document of part of our physically responsive behaviors chart. We structured the document through 3 columns, one which is language we would prefer not to see used as often, language to avoid. The next column is a definition or context to provide around that definition of the word. And then the third column is examples of preferred language. Now, I want to put in a caveat. We're not saying that these words should never be used. There are definitely times when it's appropriate to use these words, but what we ask is that they be used with more elaboration and more objective description to facilitate understanding. For example, look at the words there, inappropriate behavior. That might mean one very different thing to me than it does to Deb, than it does to Ken, than it does to you. It's much more helpful if we say the person unbuttons their blouse in the dining room than it is to say, for example, that they're having sexually inappropriate behavior. Or let's say instead the person unzips their pants when walking by the hallway bathroom. Because there's a lot of different things that could be causing this, and unless we describe it clearly and objectively, we won't do that deeper dive to try to figure out why are they unbuttoning their blouse or unzipping their pants? Are they hot? Do they have a yeast infection? Do they have urinary retention? So just labeling them as inappropriate sexual behavior does nothing to further that deeper dive into managing the responsive behavior. This slide shows some of the verbally responsive behaviors and a language that we would rather not see used. For example, screamer. The definition there you see it's frequent calling out in a loud tone or repetitive requests for help. So what we would prefer to say, for example, is the person is repeatedly calling out their spouse's name during morning care. Much more of a clear picture if I'm, for example, in a long-term care facility and I am getting documentation from the hospital about this person. This gives me a little bit more of a clue as to how might I manage this behavior, how might I figure out what's causing it, rather than just seeing that they're a screamer. So what we have suggested with regards to this document, because it's not enough for a document just to be written and stored on somebody's hard drive somewhere. This document has to live and breathe. And what we are asking, or what we are thinking about, are potential applications in our TAHSN community of practice. So, for example, we're hoping that this will be used to guide written and verbal communication at transitions of care, whether it's in hospital or whether it's hospital to community, and to encourage appropriate language in face-to-face discussions. So at TOA for change of shift, when one care provider is handing over to the next, that they use person-centered language, as instead of saying, oh, I have the screamer down the hall and she screamed all night long. I'm so glad you're here. We also are advocating that this document be used to influence education at orientation for all health providers, physicians, staff, student learners, and volunteers, and to have this person-centered language woven into educational materials as well. Within our TAHSN community, further to this is we also suggest that the person-centered language be used when creating care plans. Again, as I said, it helps to create a targeted care plan. So, for example, if you wrote in, if it was written in the chart that Mary-Lynn was aggressive yesterday, you coming on and looking after Mary-Lynn today, how would you know what the aggressive behavior was? Aggressive to the person who documented it yesterday may not be the same as aggressive to you today. But secondly, how would you know if your care plan was making any difference if you don't know what the aggressive behaviors were and if they're getting better or worse? So much better if it said, Mary-Lynn struck out when approached from the right-hand side. That gives you a clear picture. Then you can say to yourself, maybe I approached Mary-Lynn from the left. And then it also gives you a picture of, oh, okay, maybe this isn't happening all the time. It's only when someone comes up towards her from the right-hand side. And then maybe you do a deeper dive and you go, oh, maybe she's got some right-sided neglect and she can't see you when you're approaching from there, so you startle her. So again, the language we use has that ability to impact how we create our care plans and how we evaluate our care plans to know whether or not we're making a difference. We are also advocating that it can be used to assist human resources personnel when they're doing a hiring of people to assess their sensitivity to senior-friendly strategies and approaches amongst potential applicants, because we know, let's be real, a good chunk of patients who come into hospitals are older adults. And whether you work in neurology or cardiology or renal or critical care, chances are you're going to have an older adult. And so we are advocating that we do some assessing for sensitivity to older adults and senior-friendly strategies when people are hired. Also, we're advocating that person-centered language influence policy development. For example, in delirium policies or in restraint policies or policies about constant care or sitters or observers. This slide is touching on the impact of person-centered language. So if we start at the very top blue circle that says increase in staff perceptions of personhood. So if we use clear, objective, person-centered language, we just naturally are going to come to think of that patient as a person who is having a responsive behavior rather than the screamer, the wanderer, the exit seeker. So we start to think about people more as persons, and that helps us to have targeted care planning. We suspect that this would also decrease the use of pharmacological interventions for responsive behaviors when we look at people more holistically and are more aware of what their triggers are, and then perhaps ameliorate those, which then should reduce violent incidents for staff and patients. And that has the potential, this one is huge, that has the potential to change discharge destinations. We all know that certain words are red flags in charts for care facilities in the community. If they read charts from the hospital and see certain words, that rightly so makes them concerned that they may not be able to manage this person's behaviors appropriately given their staffing and their levels of supervision. But if we describe things objectively, if we are then maybe able to reduce violent incidents, we have the potential to change that discharge trajectory. And that increases patient and family satisfaction. So I'd like you to ponder for a moment, and maybe you could chime in on the chat board for this, how you might now describe delirium or behaviors of dementia. Do you think that you might be able to use different words now to describe a delirious patient who's calling out and pulling out their IB, or somebody who is trying to leave the unit, repeatedly following the nurses to the exit doors of the unit and trying to leave? Are there new words now that you think you might use?
And again, feel free to type in your chat box, bottom right of your screen, and that will be there for all to see.
Or does this, have I asked too broad of a question? I realize it's a bit different on a webinar than it is in a classroom, but can you give some thought to that?
I do like how you framed it, both Deborah and Mary-Lynn, because just that switch in thinking will change us from our natural response, and our natural human response of anxiety when we experience something that's uncomfortable to us. And instead of spreading that anxiety to our teammates, to other organizations, and ultimately back to the patient we're caring for, we launch into a different mode of thinking that encourages query and problem solving that will help us achieve more brilliance in our clinical care and help us optimize our delivery of senior-friendly care. And I think that's the core of your message, if I'm getting that right.
You've got it. And I like that he said that we had brilliance in clinical care. Because we do. Yes. All right. I think I'll move on then to the next slide. And let's think back to our case scenario, our Mrs. Sharp. Let's think about how things could have been different if person-centered language had been used. For example, what if it said on arrival she was attempting to strike out at the paramedics when they tried to restrain her in the ambulance? Does that give you a slightly different picture? What about the ED documentation? What if it said she was not able to lie still in bed, or she tried to push staff away when they attempted to take vital signs? Instead of saying that she's restless and agitated, we now have a different picture of what Mrs. Sharp was like. And now, with those words, the ED physician on call felt that they didn't need physical restraints and that we didn't have any acute safety concerns because she was verbally redirectable. Mrs. Sharp then made it to the inpatient unit. She still needed to be admitted to hospital because, yes, she was still delirious and she still had uncontrolled rapid AFib. But now on the inpatient unit, they're saying things that are very clear and objective. They're saying she is not oriented to person, place, or time. That gives us a much different picture than just saying she's confused. It now says she had difficulty following one-step cues when there was a lot of noise in the room. Again, very clear, concise, and objective. She tried to push the caregiver away intermittently with attempts to administer medications or provide peri-care. Great. These ones give you a clear picture of how she's doing and also maybe how you might change your care and monitor whether you're making a difference or not. So how did this team care for Mrs. Sharp? Well, they turned off the television when they were providing instructions because they realized that she concentrated and was able to focus better when there was no verbal and visual distractions. And secondary to that, they closed the curtain to reduce those distractions. They told her what they wanted to do before they did it and made sure that she understood. Rather than going in and just starting to take her blood pressure, they talked to her about it and involved her in her care. They also kept the conversations with her positive. They told her what she could do to help and not what she couldn't do. Not, don't get up, you can't leave the room, call the nurse for help. It was, let's help you walk, we will walk with you to the nursing station, we will walk with you to the bathroom. It was very positive. And they were able to find out that she liked music, and so they used music for relaxation and distraction. They also recognize that sometimes you have to step away and return a second time to provide care. Sometimes you have to take your agenda, put it in your back pocket, and go with what your patient's agenda is. And if your patient is saying to you, no, I don't want pericare right now, then you stop and go away. So Mrs. Sharp, with this new responsive care, was medically stable by day 4 and was participating intermittently with physio and OT. But she very differently was close to her functional baseline because she had not had all of the antipsychotic medication and she had not been restrained. And we were able to transfer her to an inpatient rehab facility where she was discharged home 3 weeks later with some community support. The big take-home from this is that the language used seems less of a shutdown and more of a cue for creative brainstorming and enhanced and targeted care planning. And this is really what we want you to think about, is how the impact your language has. The next slide, sorry, I hope you can't hear the overhead page that's going on in the background.
And we apologize from a content perspective. That was a code white announcement we just heard. So
that's ironic.
Perhaps there are some different approaches being exercised as we speak.
Yeah. Okay, so they've stopped, so now I can carry on. So what we've done with implementation of this person-centered language guideline in our TAHSN community is that we are developing an implementation and evaluation plan along with teaching resources that will be shared across sites. And we've been collaborating with our other community partners who share our passion for person-centered approaches in understanding and describing language. We do need work to do to make this real, and so therefore we've been working on all of these linkages to the community, ways of taking this from words on a page to actual action and care planning. One of the partners that we've engaged with is the Behavioral Supports Ontario. And the evolution of the person-centered language with responsive behaviors in our TAHSN community has led to natural synergies with the works that the Behavioral Supports Ontario is doing. And Deborah Brown and myself have been invited to become members of the Non-Stigmatizing Language with a Dementia Focus expert panel. The Behavioral Supports Ontario group is currently in the process of creating guiding principles on non-stigmatizing language, and they're hoping to inform the authentic voice of persons with lived experience and to promote consistent use of person-centered language that's appropriate, respectful, life-affirming, inclusive, and non-stigmatizing when talking about dementia and individuals living with the diagnosis of dementia. The group's action plan includes the release of a final document in 2018, and if you want to be kept informed of the release of the final document, consider subscribing to the BSO Provincial Pulse e-newsletter. And there is you'll see on your slide there, you'll see the web address where you can get that. So at a more local level for me, how have we operationalized person-centered language at my organization, which is Trillium Health Partners in Mississauga? What we have done is integrate person-centered language into some of our policies. We have started with the ones that right now are focused on older adults primarily, which is our constant care policy, our restraint minimization policy, and our delirium policy, which is in development. We have also integrated person-centered language into some of our education modalities. We've held person-centered language workshops. We've held a series of behavior education fairs called Delirium Days, affectionately, but that was not the working title. I was told I couldn't say that, so it was Behaviors, Yours to Discover, or A Journey of Discovery. And we've also incorporated person-centered language in our orientation and during various Seniors Month activities. And we have in development right now an online delirium learning module that incorporates person-centered language. We also have integrated person-centered language into some of our forms, such as our behavior observation log. and we have integrated it into some of our corporate initiatives, such as our senior strategy and something that's occurring at our organization called the Medical Psychiatry Alliance. And we have shared this with our local LIN. This next slide is a screenshot of our behavior observation log. On the right, you can see that it is the full size of it, and then the bit on the green in the left is a blow-up of the legend at the bottom of the behavior observation log. But we chose, you'll see that we chose person-centered language for the patient behavior section on the left. So instead of, for example, saying aggressive, we have written physically responsive behavior. And instead of saying screaming or shouting, we have verbally responsive behavior. Instead of exit seeking, we've written trying to leave the unit. And so those are the behaviors that can be documented in the behavior observation log along with actions that are taken. And this then facilitates objective appraisal of whether or not the interventions are making a difference on the behaviors. And now I'll pass the baton back to Deb to talk about how these have been integrated here at Sunnybrook.
Thank you, Mary-Lynn. And what you see is a snapshot here of our intranet site at Sunnybrook that we call SunnyNet, and we do have a page on our intranet called Senior Friendly, and we have developed actually most recently 6 e-learning modules that really does serve as an educational tool or educational tools to help staff with their knowledge around senior-friendly care. And we do have one specifically on responsive behaviors and the use of person-centered language. And these e-learning modules are very short and interactive, and we're just rolling them out. We're hoping that they're going to be successful tools for staff to use. The other things we've done, we've started to incorporate in our orientation the concept of responsive behaviors and person-centered language, and have updated and revised several policies to be in alignment with this movement. The first one is our high-risk behavior policy, and we're currently working on our leash restraint policy and incorporating language in there, and our observer guidelines as well. So it is a work in progress, and it's something that will always be, I think, an ongoing piece of work that needs to be done, because the language and perspective on care and attitude towards care must permeate practically everything in an organization. Not only education, but your documentation on paper, electronically, and then we have to work with our partners in the community as well, who require documentation that isn't person-centered, and we have to look at trying to get some of that changed. So that's a little bit of what we're doing with this at Sunnybrook, and I know that we have some folks online from some of our other TAHSN organizations that will probably or hopefully highlight what's happening in their organization as well. Thanks, Mary-Lynn.
All right, so now what we're going to do is you'll see on this slide we have 2 questions. So the first question is, how would you put this into practice at your institution to generate improvement in care and service? And for this, we're asking that you think about what you might do to make this real, as I said, to take it from just words on paper into real-life application where you work right now. Feel free to just type in a few words in the chat box about what you might do.
Yeah, we're interested in hearing any ideas you have, even very small ideas to larger ideas, but thinking about what we've said about person-centered language and the idea of understanding beyond the pathology of the patient, of considering what's beyond the pathology as to what is happening with the person and developing care plans that are targeted. How do you think this might look in your current practice setting? What could you do to help translate some of this knowledge?
I'm happy that Deborah and Mary-Lynn are asking this question, because this is brainstorming for potential quality improvement ideas. that you could feasibly implement. And think about the framework for senior-friendly care, and I can send a link to that out if you're not familiar with what I'm talking about, but ideas can fit in any of those framework domains. I mean, organizational support. Is it a policy that you wish to advocate for at your organization? Is it education for your staff? Is it a process of care? Is there something in the care plans you might look at changing that could be feasible? The physical environment, perhaps. Is there lighting or sound changes you think you can make that could provide a more soothing environment that might minimize the behaviors? So I've touched upon a few of those domains, but think about anything and everything that might contribute to the overall, I'll use the term again, clinical brilliance that we're all capable of. We've got some people typing.
Yes, type.
Yeah. I mean, I think even we've talked a lot during this webinar about just reframing the issue from, an anxiety-inducing problem to, an approach of clinical query and problem solving. I mean, I could think of even a poster encouraging that, and maybe linking to the document would be a great first step because, to this, I think awareness is key.
And sometimes, Ken and Mary-Lynn, it's not just about always providing answers, but providing the questions that cause people to think and come up with the answers on their own.
Right.
Because this whole process is really very much of a aha kind of moment process, because when you start to think about the impact of language and the trajectory that follows with that, it does make sense. And it does make sense that we need to probably change a few of our approaches. And it's not the whole package. Responsive behaviors and caring for patients with dementia and delirium can be very complex. This isn't the whole package, but it's the beginning. It's sort of a foundational approach to getting where you need to go. And we feel fairly strongly about that, and we hope you do too. But we'd like to hear some of your ideas, or even if you don't want to answer that question, just what are your general thoughts about this?
And just to build in some housekeeping stuff, we are recording this presentation. We're going to send you an evaluation with a link to this recording into the slides. And as a start, if you found this was helpful, you could recreate this as an in-service or lunch and learn in your organization. And that in and of itself won't require extra work on your part to create anything, but hopefully a ready-made resource that you can use to spread the awareness of this way of thinking.
Yeah, that sounds wonderful, Ken. Yeah. Lunch and Learns have been usually a very good vehicle for engaging staff.
Oh, if you feed them, they will come, as they say.
And I noticed another question there. Maybe we could just pose that so people can think about that as other answers are being typed in.
So if you were putting something into practice in your organization, how would you measure it? How would you know if it was making a difference? So think about maybe if you were doing some education sessions, how would you know if they were making a difference? Or if you were trying to change documentation, for example, in behavior observation logs, how would you know if that was happening? What would you do to track that?
So I'm thinking, Mary-Lynn, chart audits, certainly from a language perspective, would be probably a potential valuable thing. Looking at if you keep a formal process or a documentation process with transfer of accountability processes, there's a key for looking at language and the kind of language that's used from your ER to your wards, or ward to ward, or from facility to facility.
Right.
I think it might be also interesting to look at our discharge destinations, and if the language starts to change, do people get to where they need to be in a more person-centered way? Do they get to where they want to be as opposed to where they have to be as far as discharge goes? And even looking at, length of stay, even though there's many variables with length of stay, but patient satisfaction, family satisfaction, and staff satisfaction as well might be ways to measure the effectiveness, because staff satisfaction would eventually, I think, improve.
Yeah, these are all great ideas, and I also think of the problem isn't just our problem or your problem at your organization, but when we think holistically of the senior-friendly health system, when a patient is transferred or discharged to another institution, what would be a quick way of soliciting, how satisfied were you with the language and care planning we provided you to prepare your readiness to care for this patient that otherwise we would find very challenging without this information. So even just a one question, how satisfied were you with the language and documentation that accompanied this patient? And that goes a long way in building smooth transitions and a more senior-friendly health system.
Ken, I couldn't agree with you more. I think even if we asked, or especially if we asked just that one question, and we have to be brave to ask that question because you have to be able to listen to the response you get. But I think that would be would have a huge impact in also improving patient care, but also improving the trust between organizations. And we all know that there can be a real issue with trust. And so that would be one of the ways to really get to improving care and improving collegial relationships.
Yeah. So we do see a lot of people starting typing, and we'd love for you to finish your thoughts, because we would love to hear from you and have you share some of your thoughts and stories as well.
So with that, I think I'm looking at the time and recognizing that we only have a few minutes left, so I'd like to take a moment to acknowledge the working group members that contributed to the development of this TAHSN senior-friendly community of practice, person-centered language document. How's that? And so as mentioned at the outset, Deb and myself were the co-leads for this working group, but with us in the working group are Lori Whalen, Catherine Reese, Christopher Urani, Sylvia Davison, Nicole Spira, and Leanne Ginty. Sorry, Leanne. And you can see some of our member hospitals in the TAHSN group, and we've got a very nice representation from a variety of the TAHSN organizations. So a very big thank you to all of them, because this would not have happened without all of their hard work. And with that, I think we will leave it as if you have any questions, anything you'd like to comment on, now's your chance.
Yeah, we do have, so it's an open discussion. We do have a couple minutes left, and I'll, sort of start wrapping things up, but we do want to hear from you, and in particular, I'm giving silent applause, big applause to our presenters, Deborah and Mary-Lynn, for presenting this topic in such an articulate and friendly fashion. We welcome any comments you might have, and to add to the discussion, or even to acknowledge Mary-Lynn and Deborah who've worked hard on this presentation. We see a few of you typing your responses in, and as you do that, and we will continue to stay around and respond to you, my email address is at the bottom of this slide, and I will also work as your liaison. We will send links to the guideline report as well as the recording and slide deck to this presentation. But please, if you want to engage with Deborah or Mary-Lynn further and discuss more about, they touched on a number of topics, not just clinical care, but Mary-Lynn presented some of the system initiatives going on with the Behavioral Supports Ontario work, as well as some QI thinking with our discussion questions at the end. If any of these you'd like some richer discussion with, I'm happy to connect you with our presenters. You will automatically, in a couple hours, receive a evaluation survey by email, and that will contain the links to the slide deck and the recording to this presentation. If you like us enough to come again soon, we have a webinar on Tuesday, and this is a dual trained and dual registered professional. She's both a doctor and an architect, who will be talking about geriatric care and the influences of the physical environment. And on March 14th, 2 weeks on, March 13th, March 14th being the official World Delirium Awareness Day, on the 13th, the day before, we have Nevo Regan presenting an update on delirium screening and detection. And there are a couple questions there I'll turn to Mary-Lynn to answer.
All right. Thank you, everyone, for jumping in with some comments and questions. We were starting to feel a little lonely. So I'm noticing here there's a question from Maria, or a comment, and it says, in terms of language, having proper medical terminology in a patient's file is equally important. Saying a person has dementia is not part of their diagnosis. This term just describes a set of symptoms, but it would be important to know what is the cause of the dementia. I think that's a valid comment. It definitely does have a bearing on the person's clinical care, depending on the cause of their dementia. For example, if it was a vascular dementia as opposed to an Alzheimer's dementia. The dementia, or the diagnosis of dementia, should not become the person. So, and that's what we're advocating, that it should be broader than just dementia. It should be a person who maybe, oh, by the way, has dementia, and here's why, and how we care for them.
I agree, Mary-Lynn. But I also concur that having the kind of dementia and the accurate medical terminology is important, because your care interventions as a practitioner or a nurse looking after that patient is influenced. For instance, the person has Lewy body dementia. There are certain things and you would and would not do in relation to treatment for that patient. So yes, we totally agree that that's important, but it doesn't become everything.
Right. Now there's a couple questions about the learning modules, and so it looks like several people are wondering whether they can be shared with other organizations.
Yes, you can certainly go through Ken and contact me personally. We're just piloting the e-learning modules. We're going to probably put a few tweaks to them. So I think after that is done, we'd be happy to share. But yeah, please just contact me through Ken, and we can dialogue about that.
Lovely. And then the last one, do we have time to answer this last one? Okay. It is, I believe there was a working group that was going to update the DOS to make it standardized for various sites. Is the behavioral observation related to this at all? It is not part of a DOS revision working group, but at our organization, it replaces the DOS. And we are using the behavioral observation log for all behaviors, not just dementia behaviors, and that's why we chose to move away from using the terminology DOS. But it is essentially that.
Great.
Very good.
We'll stick around for maybe another minute or so if you have any last questions, but I've thanked our speakers and hope they're receiving your applause right at this moment, because they've come a long way. Deborah from down the hall, but Mary-Lynn from across town to deliver this presentation and all the useful information within it. But thank you as well for tuning in. We love hosting this, and we love that your continued interest in our webinars. On behalf of the RGP of Toronto, who brings you this webinar series, my name's Ken, and my contact information is there, and I'm happy to hear from you for further assistance on these topics. Thank you all.
I just realized we missed a couple of GPA training. Sorry, everyone. I noticed that I inadvertently skipped over a couple of questions, and one was about GPA training. And that is something that our organization is embarking on. We have some GPA trainers within the mental health program, and I am currently in the process of having 12 more people certified as GPA coaches to help with dissemination of GPA education across the organization, because we feel very strongly that there's a natural link between GPA education and person-centered approaches and language.
Yes, I agree, Mary-Lynn. I think there is a very strong link. And certainly within our Sunnybrook sites, we've had one of our sites embrace some of the embrace this GPA education. So we certainly would invite you to look into that as well.
I think that's it. I think we answered everything else.
So thank you again to Deborah and Mary-Lynn, not just for a great presentation, but also for providing us with this encore and answering these additional questions. Thank you for tuning in, and we look forward to seeing you again, hopefully on February 27th. But in the meantime, have a lovely afternoon. Thanks again.